Welcome to the Curated Beauty Podcast. Jessica Christie here, a health and beauty enthusiast who became a medical practitioner to be the authority on how to enhance both your outer beauty and inner beauty for the most confident glow. Founding and owning a multi-million-dollar aesthetic medical practice in Michigan, my mission is to bring all the bi-coastal innovations to the fresh coast of Michigan. From which aesthetic treatment gives you the most bang for your buck to how to create systems to be both professionally fulfilled and still have freedom of time and relationships, we will be diving into it all. Welcome back to the Curated Beauty Podcast. This is Jessica Christie speaking, and we've been talking about a lot of ways to navigate this crazy world lately and how to just be your more authentic self. But I also want to circle back sometimes and talk about what we actually do in aesthetic medicine and highlight some topics that are hot topics where there's a lot of change occurring. And I really want to talk about an issue called melasma. Melasma, for those of you who know what the word is, there's a good chance you may suffer with it, or you are in the industry and you know all of the people who suffer with it. When I came into medical dermatology as a practice, I was really unfamiliar with the term. And even from 2013 to 2023, 10 years later, we know a little bit more about it and we know some other better treatment options. I remember this patient, she was skin type 4, she was of Asian descent. And at the first dermatology practice that I worked at, we were treating this woman who had, now looking back, I'm like, oh my goodness, I can't believe what we were doing. She had really bad melasma in her mid-face and like these patches. For those of you who don't know what melasma is, it is a dyschromia that has a lot of factors that can play into it. We see women have a higher incidence, a little bit darker skin tones sometimes have a higher incidence, hormonal changes, whether it be pregnancy, that's a high prevalence of when it shows up, or oral hormonal therapies. It was a really bad case of melasma, but at that time, to no fault of hers, I don't think the dermatologist really didn't know how to manage it. So we were using intense pulse light on this woman's melasma and it was getting worse and worse and we were shocked. And then we used, I think, a 1540 laser on it, which is inducing all this heat. And then it got worse and we were shocked. And now looking back on it, I just really am oh my gosh, we did this woman such a disservice. I hope since then she has found other practitioners that had a little bit more advanced treatments for melasma, but we were scraping the tissue with a curette and then putting TCA on it, which also can cause worsening of melasma in some cases. But actually chemical peels are typically really good for melasma. But I digress. I'm basically telling you that even in a professional field with a very smart doctor, we didn't fully understand this condition. And now here we are with a lot more information that's coming out in terms of publications and peer-reviewed studies. But I think a lot of people, especially in our aesthetics industry, are not keeping up with what is the cause and what are the new upcoming therapies that we could be using. So today I just kind of want to brush over what's happening, who is subject to this, and kind of maybe even how we can improve this a little bit. I talked about the hormone changes, being female. There's also a genetic component that is causing people to be more sensitive. There's a cutaneous phenotype that is causing people to be more sensitive to getting melasma. This is reported to be 41 to 61% of patients in Brazil, including identical twin sisters, are experiencing this genetic prevalence, and familial melasma is really being seen there. And then the probability of being then pregnant or inducing some sort of hormonal contraceptive is showing us that we're seeing this increase and this rise in first-degree relatives. So skin pigmentation really does follow an inheritance pattern, and we're able to see that, okay, for the first time, there is a genetic component. There's also an inflammatory pigmentation component, which I think is important to mention as well. And that is something that I think besides sun exposure, which we know, and besides hormone, which we know, there is this kind of component of inflammation that I don't think we were really truly appreciating until recently. So when we have things like cutaneous inflammation, like this woman who we were like really inflaming her skin with TCA. Like TCA was a good thought, but for her, it was not probably what she needed. And melasma is so multifaceted, you guys, that you could try one thing that works on one person and then the next person, it doesn't work. That is the buy-in and that's the patient education. Like this is going to be a long trial and error type of condition that we're going to have to figure out what works for you. In terms of eczema or contact dermatitis or those types of things, like that can really increase someone's melasma predisposition as well. So really looking at what can we do about this, that is where we are now. This is understanding there's really no cure, but how can we look at what's happening and then potentially improve it? So number one, sun protection is going to be key. That's why people should start early. You don't know if you're going to be predisposed to melasma until you get it. Then from there, we want to make sure that we're using something with a physical sunscreen rather than chemical sunscreens, because the chemical sunscreens can actually flare parts of the melasma. So I like mineral-based sunscreens. I really, really like a tinted mineral sunscreen because that's going to give you another layer of protection. And rather than a chemical sunscreen where that's absorbing into the skin and it's changing how you're absorbing the ray, physical sunscreens are really important because you're just blocking the ray in general and it's bouncing off of your skin. So you're going to look for ingredients like zinc oxide, really. There's also titanium dioxide. That's also getting a little bit of a controversial name. However, zinc oxide is a really good ingredient. And it's also important to point out here that even the blue light that we're getting from our computer screens and our phone, that is contributing to that radiation that we're getting on our skin that could potentially be triggering melasma. So rigorous sun protection is so important. And actually the darker skin types a lot of times think they don't need it, or when we're younger and we just think a tan looks so good, there you go. You're really setting yourself up for failure. When we move on from sunscreen, what else can we do topically? So hydroquinone has been something that kind of interferes with the melanogenesis, or it inhibits that tyrosinase, which is a pigmentation creator, and it causes these melanocytes to form melanosomes. And this hydroquinone theory and proven treatment really is that it inhibits the DNA and RNA synthesis that alters the formation of the melanosome. The problem with hydroquinone, it does work, but the problem with it is that it is something that should be used very intermittently. And if it's used long-term, it actually can cause some rebound pigmentation that's worse. The other part of it is you cannot use it in pregnancy. And there's a lot of concern with irritative contact dermatitis, this concept of confetti-like leukoderma, redness. It can cause more telangiectasias. And melasma, I'll get to this later, but also is an issue of the vascular system. So is it really the best treatment? No, we have better things now, but for a long time that was considered the gold standard. Actually, the gold standard was using, like there was a product called Triluma, and effectively it had tretinoin, hydrocortisone, and a steroid. So we're putting something to calm inflammation, the hydrocortisone, which was inhibiting that tyrosinase, and the tretinoin to help slough off those dead skin cells. I get where we were going with that, and I'm not saying it's a horrible treatment, but it definitely requires someone that knows a lot about hydroquinone and really good intense patient education. Plus, I don't want my skin to become more irritated by something I'm using. And if I can't use it when I'm pregnant, it makes me a little nervous. I don't know. It's maybe the crunchy granola hippy dippy in me. Okay, let's talk about other topical therapies. We're seeing really great things with azelaic acid. This is going to be a weaker tyrosinase inhibitor, but you can use this during pregnancy, breastfeeding. It's really well tolerated. And if you can get like a 20% cream to use twice a day, that's really effective. We have niacinamide, which is a form of vitamin B3. That is really helpful at decreasing kind of the inflammatory type of action and also stabilizing the epidermal barrier. We'll get to a little bit more of devices that we can use to do that as well. In melasma, 4% niacinamide really led to a great reduction in the reflaring of melasma. And so that would be a great option. And it's also readily available. Even you can buy it on Amazon. There's other things like L-cysteamine, thiamidol, other topical things that we've considered like vitamin C. Vitamin C is super unstable as of now, but There are other lighteners, brighteners like kojic acid, arbutin. Those types of things are really going to be great. And then just keep in mind, you're looking for antioxidants, things to protect you against that oxidation. Glycolic acid is also phenomenal. I love our clear pore pads. They have glycolic acid. But I would really highly recommend people do not use steroids on their face. You'll see that in a lot of publications. Oh, go like put clobetasol, which is a potent steroid. We are not going to put that on your face. No. And then the tranexamic acid, there's topical versions. There's also oral tranexamic acid that people are using for melasma. Other things to note orally, metformin is a diabetes medication, and that is inhibiting melanogenesis. Metformin is interesting. There's a lot of studies on it being like maybe some anti-aging drug. Thought about taking it, but I don't want to mess with my blood sugar. I don't know. Maybe that's really ignorant, but I need to do more research. And there's methimazole, which is an oral anti-thyroid drug. And that is also thought to be inhibiting like the peroxidase, again, inhibiting eventually the tyrosinase and melanocytes. I don't think that you should be taking thyroid drugs if you don't have a thyroid problem. Like, let's maybe back it up. But just so you know, there's lots of things going out there. And like touching back on the tranexamic acid orally, it's like, okay, give me that then. But there are side effects, back pain, musculoskeletal pain. It can mess with your menstrual cycle, abdominal cramps. This drug is used for blood dyscrasias, and typically it's 250 milligrams twice daily for 2 to 4 months. So it's not like you're on it forever, but there was a deep venous thrombosis 6 weeks after starting therapy in one case. I don't know, like, is that enough to make you not do it when you're struggling with melasma? I think it's definitely an education component. I really want to kind of move on to the other treatments that we can do in office. Chemical peels are phenomenal. There's a whole bunch of different ingredients that work. TCA, which is trichloroacetic acid. There's glycolic acid, which I already mentioned. Jesner's solution, which is a combination of resorcinol, sal acid, and lactic acid. So there's lots of different things. My two favorites, I have a VI peel in our practice. I like the Precision Plus formula, which there's brightening agents in it more than just hydroquinone. Also, I just brought on a new peel called BioRepeel, which has a high TCA but low downtime. You really don't peel from it. Plus, there's tons of other things. Sal acid, GABA, antioxidants, like really, really good. Maintenance for melasma for sure. I love the Silpherm X device, which is a continuous wave and pulse wave treatment. The pulse wave is going to actually treat pigmentation because it's repairing the basement membrane. The reason that melasma just goes ham is that we are seeing these melanocytes like just acting out. It's like little toddlers. Like, you got to give them parameters and borders. They're going to calm down. So I really like the concept of actually repairing the basement membrane. Also, we can put some of these things topically on too, like pairing Silpherm X with a BioRepeel is amazing. And then also introducing exosomes, which have tons of really good growth factors to support healthy blood vessel formation and minimize pigmentation. Like, just so good. Let's talk a little bit about lasers and light. So there are people that will use IPL or BBL devices on melasma. I don't really agree with that. I would never do that. I think that you may be covering up a problem, but you are not adding to the solution. We're not putting Band-Aids on things. We want to give people solutions. Maybe it's long-term. Maybe it takes a little bit longer to see the beauty of it, but we really want to explore things that are going to heal and actually treat. Again, it's not curable, but can we do better? We always want to ask ourselves, how can I do better? So we talk about things like the Q-switch lasers. Those are things that are really helping deliver energy into like little short bursts, like nanoseconds. Looking also at the halo laser is great. It is really helpful, but I'm telling you, Moxie is even better, I feel like, for melasma. We've seen incredible results with a series of melasma. And again, it's a marathon. It's not a sprint. But we want to essentially focus on things that lead to less inflammation and less post-inflammatory inflammation and hyperchromia, because that is obviously mitigating what we're trying to do. We also want to stay away from things like CO2 because you're asking for issues. There are people that do it, but ablative lasers that have a high thermal effect can result in dyschromia. We want to keep the short pulses, like low energy as possible, and help to repair that basement membrane. So let's talk a little bit about the hypervascularity epiphenomenon in melasma. So a pulse dye laser can be really helpful because it's treating that redness. And so again, due to the risk of post-inflammatory hyperpigmentation, we don't want to use it in too high of phototypes, but there are devices coming out there that are really helping us kind of hit all of these little boxes and really find some good solutions. So I want to just kind of round out by saying that the treatment of melasma is challenging. Do we all have the answers? No. And as the spots are not cleared completely in most patients, it's really important that we educate our patient that this is something that we can make better, but it's a long-term relationship with us. Hook yourself up with someone who's doing it well, takes care in looking at these publications and reading the most up-to-date papers and making sure that they are on good skincare. You can do a lot at home. Find an Instagram account like ours. Like, we provide so much education on what can you do at home. I'm telling you guys, home therapy is like 80%. If you are preventing, prevention is key, just like everything else in medicine.
Congratulations, you have done it. You've reached the end of an episode on the Curated Beauty Podcast and have enriched a part of your self-care by discovering something new. I hope this time together added a little perspective to your day and will ultimately boost your confidence and give you the strength to do all the hard things. As we walk through this journey together, follow our Curated Beauty Podcast. And if this resonated with you, share it with a friend, save the episode, and also follow our social media platforms in the show notes. We love to engage with our listeners on all levels.